Welcome to the Nobody Told Me That podcast. My name is Teresa Duncan, and my goal is to share information that you probably weren't thinking about. I love preparing my friends for situations that may come completely out of the blue. I also want to share with you many of the tidbits I picked up over the years. If you absolutely have to tune out before the end of the show, make sure to check out the show notes for more details on today's topics and information about my online class, Dental Insurance Design and Management. And thank you so much for making me a part of your day. I'd like to give a shout out to my friends at Synergy Dental Partners for sponsoring our podcast. They know how important the admin team is to our industry. Synergy is a group purchasing organization, or GPO. GPOs reduce your overhead with lower supply costs. They also have partnerships with labs and various service providers. You owe it to your revenue cycle to check them out. They're giving Nobody Told Me That listeners a 2-month free trial and a $200 Darby credit for new Darby customers. For more information, check out the link in the show notes or go to odysseymgmt.com/synergy. Hi, welcome back to another edition of Nobody Told Me That. It's just me this time. I am flying solo on this one. I gave a webinar recently, and I'll put the links in the show notes, for Vine, and it was called the Mid-Year Insurance Check-In. So for those of you who are maybe new to the podcast or new to me, every year I give at least 2 webinars for Vine. The first one is in January, and it's called the Coding Update for whatever year we're in. And I've been doing this webinar for a while. It was with NEA, and then it was with Vine. And so it's been, I think we're going on our 7th or 8th year. I'm not really sure. And then in the middle of the year, we do a mid-year insurance check-in in which we go over how to position yourself for the rest of the year, open season. And I talked a little bit about Medicare Advantage and what some of these plans are going to mean for you. So at the end, as always, I had a ton of questions. And as I was going through and answering them, I thought, you know what, maybe I should just share them with the listeners. And now that we're up on YouTube, I thought it'd be great to have the questions up on a slide and give you the answers so that you would get the same answers I would share with whomever was asking the question. And so what I need to do now, for those of you who are on audio, you don't have to worry about this, but what I'm going to do on video is share my screen here so that you can see what the questions are. So we'll go through a little bit of the questions. I'm going to read them out, give you the answer, and then in the show notes, you'll get the specific questions so that if you need to, you can reference them again. And I do have some links that I will also put into the show notes. So first things first, one of the most confusing issues that we have right now is umbrella plans, or what we call lease networks. And one of the questions was, what is the best way to know if we are on an umbrella plan? We seem to be getting surprised left and right. Is there an easier way to obtain the information? Okay, so this is a very, very common problem, because once you decide to get off network with one plan, you think you're doing great, and then all of a sudden you are now back under somebody else's umbrella. So what needs to happen is, first of all, I always advise that you have all of your contracts that you've actually signed, the ones that you've signed, near and accessible, right? So a lot of people have what we call a master file for each carrier with which you participate. You put the contract in there, and then you can pull out and assess whether or not you're able to be leased out. So what happens is you end up sending in your termination for a plan, but you didn't realize that you were still participating with this other plan. And so the old plan that you worked so hard to get out of now pulls you in under another contract and a different fee schedule. It might be a better fee schedule. It could be a worse fee schedule. But the problem is you don't usually know until somebody comes in and says, hey, you're on my plan, and they show you the website, or they show you the printout that they got from HR. And it's very frustrating because you really believe that you're correct at that moment. And then it's very much a hit to see your name right there on the directory. So what I need you to do is really keep a hold of which plans are the ones who are going to lease you out. So there are some that do not lease out. Delta Dental has said that they don't lease out their network. Well, you've got lots of United Concordia, GEHA, Connection Dental, Dento. I mean, there's just so many that will lease out your name. And then what's even more frustrating is when they have what they call shared agreements, insurance. So you've got like Guardian, MetLife. I mean, they all just kind of work with each other. So the best way is to keep an eye on which plans you actually have a contract with, and then keep an eye on your state. Many of your states have passed laws that say they need to give you 30 days notice or 60 days, depending on the law. Then you actually have to opt in. You can't just be automatically opted out because you were silent. You didn't answer their email. And I think a lot of states are going to move to that. But for right now, it's not the majority of states. So as an insurance coordinator, there's no easy way for you to really track this other than making sure you're reading all of the newsletters that come across. As far as like if you participate with Guardian, make sure that you read the Guardian newsletter. Make sure that you have a valid email on file for them to message you so that you know what's coming down the pike. And also keep in mind that just because you see on social media that two companies are sharing networks, that doesn't necessarily mean that that's going to happen for you. It could just be in that particular region. And for example, the Guardian and MetLife issue, no, it wasn't across the board. Some offices never got that letter. And so it's not necessarily true that this is across the whole country. You have to make sure that you know what's going on with your actual zip code and your actual office. Now, the question also becomes, how am I supposed to stay on top of it? What if I just get the newsletters? What if I just do my job every day and I'm getting mail? Well, you should be notified before this happens. Typically, they will publish it in the newsletter. They will send you an email. They might even send you snail mail, but there are many ways that they're supposed to notify you. What most people get upset about is that they find out about it before it goes into effect. And it's not because they're finding out about it. It's now our thought process is, okay, now we got to work again. We got to do a lot more work. Now I've got to explain to these patients who we just got out of network with that now we're back in network, but guess what? We're going to try to get out of network again. And the patients are like, what is this ping pong that's going on? So I understand if you're not in a state that has legislation about this, about, shared network transparency, I urge you to call your dental society and find out, is there anything you can do about this? This is one thing that I know increases your administrative burden. So definitely see if you can do something about it. It's just boots on the ground is the only way you can really keep track of this. There's no magic website. I wish there were to tell you which networks you are in with. That would be amazing. I would love to do that. Okay. The next question, for certificate of coverage, can the insurance company provide us a copy or should we get it from the patient? So what this person's talking about is a topic that I bring up in class all the time, which is called certificate of coverage. Certificate of coverage is the most detailed plan booklet that you're going to get. So we get verification, eligibility, and full benefits breakdowns from the carrier. However, a lot of times it's not as complete as what is in the certificate of coverage. The certificate of coverage is what is provided to the patient, the employer, and it details everything about that plan. It goes over whether or not materials upgrade is allowed. It goes over how coordination of benefits is factored. It goes over whether or not checks are sent to the patient or to the office if you're out of network. It goes over, do they pay on area fees or do they pay on a much lower fee schedule, which is basically the lowest possible fee schedule in that area. And as an out-of-network office, that's very frustrating because you don't know if they're going to pay based on your office fees or if they're going to pay based on the prevailing really low fee schedule in the area. So how do you get the certificate of coverage? Because it gets like the answer, right? In a lot of ways it is. If I can get a hold of this, then I am much happier to do that because it tells me everything I need to know. So what I usually do when a patient calls to make an appointment, you let them know, Mrs. Jones, do you by any chance have access to your HR portal? What you can do is download everything that has to do with your insurance and send it over to me. I'm looking for a specific booklet, has to do with your dental coverage. If you're not sure what it is, just send it all over to me. I know exactly what I'm looking for. I'll find it for you. Because think about it, patients don't want to have to go through all these documents to find what you need. So it's much easier for me to say, just send me everything. I know exactly what I'm looking for. So they send it to you. And I promise you, if you've never read a certificate of coverage booklet, you will read 6 to 7 of these and you will understand plan design 1000% more than you did before. This is almost the secret sauce to becoming a very good insurance coordinator. And if you go back back and listen to the webinar, and again, it'll be linked in the show notes, I go over examples of this and where to find the ones for Medicare Advantage plans and for FEP plans, federal employee plans. So I don't want to get too in depth on it, but definitely this is something that you can explore more. But the question pertains, how do we get it? The best place to get it is from the patient. And the more you ask the patient for it, the more it's going to be easy for you to say it. And you'll get comfortable asking the patient for this. I know anytime that I have to change up my script with a patient, I have to get comfortable with it because it's not something that I usually say. And even though I've taught what to say, how to say it, when to say it, anytime that there's something new, I'm going to mess it up. So I'm going to give you permission right now that if you start to say it and you stumble over your words, that is fine. It's expected. You'll be better the next couple times. It's going to happen, right? Some of the stuff we talk about, deductibles, maximums, waiting periods, these are not normal topics of conversation. Okay, another thing that we talked about, of course, is whether or not laws apply to all of the plans that we deal with. Now, I did bring up state laws, but state laws that are passed in your particular state are only going to apply to what we call fully funded plans. So all of the plans that come through your office are either self-funded or fully funded. Fully funded, again, are the ones that are going to be governed by law in your state. The other ones are governed by the federal government under the Department of Labor. You'll probably hear the word ERISA. That's what has to do with it. So how do we explain the difference? Okay, so a self-funded plan means that an entity, so Walmart, the federal government, they have enough money to fund all of the payments for that particular plan. So the insurance in this instance actually acts as just an administrator. They're the ones processing the claims and cutting the checks, but none of the money that flows out or in belongs to the carrier. It's all funded, self-funded by the employer. So government plans are self-funded. Medicare Advantage plans fall into this as well. Very large employers like a Boeing, like a CompUSA, like a Best Buy, like a Home Depot. Those are huge companies with huge amounts of money that they can put aside and pay out of. So that's self-funded. So basically, big company, lots of money, probably not going to apply to your state laws, right? Your state laws aren't going to work on them. Fully funded is for people like me. I have just 3 employees, right? Little old me. I cannot put aside millions of dollars to pay my claims. And so I have to go to a plan that's willing to fund me while I pay a premium, and then they do the adjustments at the end. A little bit like car insurance. So fully funded are governed by the state that you're in. And so in that case, if somebody had a problem with my insurance company because it's a fully funded plan, the insurance commissioner is who they could go to because the state laws do apply. Not an easy topic, definitely. Okay, another one. When we check for plan benefits with the insurance company, can we ask each time if there is a provision or a clause for materials upgrade? And if so, how can we ask in a standardized way where the rep understands what we are asking? I cannot promise that the rep is going to understand what you are asking, but we can give it a shot here. So when you're going to call, and I'm hoping you don't have to call as much for eligibility and benefits as time goes on. I'd really hope that we as an industry can move away from that. It's just such an administrative time suck, right? So what you can ask them is specifically for a procedure code such as 2740 or 2750, 52, you would ask them, are there any upgrade provisions around this particular code? And they would say, I'm not sure. You would ask them, can you put that particular code in and actually see if anything pops up, right? Because they can look up a procedure code. So if they say, no, there's nothing attached to it, then there probably is not a materials upgrade availability. Now, if you are in network, depending again on the plan, you may be obligated then to write off any materials upgrade that you would like to charge for. If you are out of network, that doesn't matter. Obviously, you're probably not even going to ask if you're out of network, right? So if there is a clause, if there is something attached to those procedure codes, then it will come up when you ask the rep. The best thing is to ask the rep to go to the bottom of the plan benefits and see if there are any materials upgrade, non-covered services clauses, and ask them for that. And yes, a couple of them might fumble through it. They might not know exactly what they're reading, but perhaps you could be nice and sweet and get them to either fax it to you or email it to you. Sometimes everything that they can see on the screen does not come through in our printouts. It's getting better, but we're not 100% there yet. There isn't one software out there or product out there yet that can give you everything for every carrier. If they're telling you you that I would be very wary. I get pitched on these products so often and I have yet to see it. Believe me, when I find it, I'm going to be telling people about it, right? So the best thing is to ask as many detailed questions as possible. Hopefully you get a rep that understands what you're talking about. You can always ask for a supervisor. That's not a problem either. You can also ask to be put back into the queue because you don't want to hang up and then go back into the long wait. You can ask to be put back into the queue so that you can talk to another agent. It's not like calling in fresh, right? If their phone system allows you to do that, they'll do that. That's been kind of a handy thing. But the best place to find this information, going back to the certificate of coverage, is in that booklet. Okay, with a disallowed service, if we had disclosed it to the patient, can we still collect it from the patient? This, as with so many insurance questions nowadays, it depends. So if you are out of network, yes, absolutely. I mean, I'm sure you're getting the gist of it, that if you're out of network, this stuff doesn't really fuddle you like a lot of it does for us, right? Those of us who still deal with a lot of in-network stuff. If you are in network, if it says disallowed and you really feel like it should be allowed, this is where you start writing appeals. This is where you pull out your grammar skills and write yourself an appeal letter, or you call and talk to a representative and find out what happened there. What if you had disclosed it to the patient ahead of time? Well, it depends on if that patient's particular contract allows them to take on the extra charge of something that's non-covered. So if the patient's contract states, yes, any additional materials, upgrades, or services is billable to the patient, most of the time that also comes with language that you need to disclose that to the patient. So I'm hoping that you have some sort of form or list of the fees that it would cost in order to have a different materials, or even I see some offices doing like a rush fee and stuff like that. It needs to be disclosed to the patient. It needs to be in writing. Almost all of the contracts I've seen have said needs to be in writing. United Concordia's contract actually states that you can bill the patient, but it needs to be in writing. And here's the kicker, it's really revocable at any time. And that really makes me nervous. I don't feel that that's fair to us as providers at all, but the patient, any law is going to side with the patient, unfortunately. Well, fortunately and unfortunately, right? Depends on what side of the chair you're on. So if it says disallowed, you're in network, the plan allows you to bill the patient and the patient was made aware, I don't see a problem with that. But what a lot of us run into is we're in that tight of a contract and the patient's contract strictly forbids materials upgrade charging, then you would be in trouble. So straight talk here is that many dentists are really taking a look at what's allowed and what's not allowed, and they're taking a look at whether or not it makes sense to be in network. Was just discussing with a fellow colleague of mine that one of her doctors is trying to bill for all on four, and they had the patient sign this big sweeping form that allowed them to bill the patient, and the patient ended up talking to the carrier and was like, why am I paying so much? And now the doctor and the patient are in this, it's not a good situation. The patient wants money back, wants to know why, and the doctor's really taking a look at, okay, if I do provide these services, I'm making zero money. I'm actually in the red because of lab costs and all of that. All on fours, not cheap services to provide. And so that's going to be a pretty hefty lab bill, and I hope they reach a resolution. I just hate to see these types of outcomes. Okay, let's go in. Same type of question here. If you are a network with an insurance and they don't allow a charge, what type of adjustment should this go under? Every time that I have an adjustment, I really don't want to put it into a miscellaneous or general adjustment category. If you're in network with any insurance companies, you need to have an adjustment specific to that particular carrier. So MetLife adjustment, United Healthcare adjustment, Delta adjustment. That way at the end of the year, say you have to write it off. There's no way around it. You end up writing it off. It's listed under Humana, for example. So you have a Humana write-off. At the end of the year, you're going to run a report, your adjustment report, and find out exactly how much you had to write off due to these unallowed or disallowed fees that you've encountered. So when you are in network, one thing you have to take a look at is how much is it actually costing you to participate That is one indication. And then I also run the report of how much it would have been had I billed out my full fee for all of these services I billed to Humana patients. And then I'm going to take a look at the difference. And then after I pick myself up off the ground, I'm going to add that to the cost of the adjustments that I wrote off. And the number is pretty big usually. Anytime that I worked with a doctor to make sure that we had this accurate, I've never ever seen this under high five figures. It's usually a pretty large amount, and it's even larger when you have staff or team members that aren't sure if they should be fighting it or not. So if there's no appeals going out the door, I guarantee you've got somebody in there that's writing off because the EOB says so and isn't questioning it. And I'm not saying every EOB is right or wrong, but an experienced insurance coordinator will know when to question it and when to seek clarification. Okay, talking about these audits regarding materials upgrades, are these audits initiated by patient complaints? And how are the insurance companies deciding that an audit should be completed? And is it at random? Okay, so I'll share my experience because every insurance company may have their different criteria. But in general, from my dealings with people who are getting audited, are scared they're getting audited because something has happened like this all on four doctor, for example, what ends up happening is it is usually initiated by a patient complaint. So the carriers, unless you are committing some crazy numbers of fraud, it's not going to show up like in their algorithms, right? If you're a Medicaid provider, typically you're going to be scrutinized a lot more. There's actual fraud programs out there that will be able to detect this information. But for, like, say you're a regular old doctor, you're submitting to Delta, United Healthcare, Humana. Okay. So those three companies aren't getting together and saying, okay, what about this doctor over here? All of this information is out there, yes, and they could analyze, I guess, if they really wanted to, but for them to do that would be such a huge waste of time. So it typically is triggered by a patient complaint. And I've been told actually by one of the larger insurance companies that even though they suspect a doctor of doing something, off, they really need to have patient complaints behind them in order to really move forward. So what if your patients really love you? Well, that would be good, right? But for the most part, when you talk about money and huge amounts of money, patients tend to question a lot of things. And I'm saying this jokingly. It's even worse when they go home and they have to talk to their spouse, and their spouse is the one saying, wait a second, why is this so much? And then you've got the other person sitting there going, oh, this sounded normal when I was there, but yeah, you're right. It does sound like a lot. Why did I sign that form? And that's usually how it happens. That's when the call is made to the carrier. The carriers are all aware of these forms that everybody thinks that is like a get out of jail free card. First thing they ask is, Mrs. Jones, were you asked to sign a form stating that this would be all years out of pocket? Yeah, I did sign a form. Then the next thing that they say is, you can revoke that form at any time. And that's pretty much how it goes. The other way that offices are getting into, some hot water is that the patient is thinking, okay, well, if it's not covered, that's fine. I have an FSA or HSA, a health savings account, flexible spendings account. So I can go ahead and submit this to them and at least I can recover some of it. Well, most of those plans require some sort of denial from the carrier that shows that it's not covered and that it would be qualifying as a procedure that they would be able to, release some money for. This actually comes up a lot where patient goes to submit, ends up saying, what do you mean you don't have a record of this procedure? Oh yeah, that's right, the form. And they revoke the form, and guess what? Now you're back to writing off a difference, refunding the patient, and the carrier's like, wait a second, this is like the fourth time someone has called and said they were made, is what they'll probably hear, made to sign a form. And so you have to be very, very clear with your patients what it is they're signing, what it is it means, and what their rights are. No matter what, the patient has the right to revoke that form at any time. And if it goes sideways, unfortunately, what happens is the patient starts to look at any of the quotes that you have as, I don't know, this doesn't sound right. And that to me is sad because we work so hard to build up trust. We really do. Okay, can I file a Medicare Advantage plan if I'm an out-of-network provider? This was another hot topic, Medicare Advantage. Okay, so most of us who are not submitting medical claims to big Medicare. So there's Medicare Advantage, which are handled by the dental plans, and then big Medicare, which is like hospital plans and, actual like big medical issues. Most of us are out of network for our Medicare. But however, you might be in network for a Medicare Advantage plan if the carrier you sign a contract with is a Medicare Advantage carrier. So many of you who were Humana contracted providers found out that now you're Humana Medicare Advantage providers. You're in network for that. Doesn't mean you're in network with big Medicare. It just means you're in network with the carrier that's administering the Medicare Advantage plan. All right. So yes, you can still file a Medicare Advantage plan if you're an out-of-network provider. That's not a problem. It's just a matter of if you're actually submitting medical procedures and all of that, that's a whole different ball of wax. And I got to tell you, I'm at the top of my knowledge with that. I am not a medical billing expert. Just a reminder to check out the companies who support the show. My friends at Synergy Dental Partners are offering 2 free months to try out their lower prices for labs, supplies, and select software services. To sign up, visit odysseymgmt.com/synergy, and the link is also in the show notes. So next question is, and this always comes in a sequence, and so it's good that we're going over this because I'm sure if one person has this question, another person is going to have it. If we participate with certain insurance companies, but not Medicare Advantage, is there required training for those who submit claims? And so this is referencing the fraud, waste, and abuse training, that if you're a participating provider for a carrier that is offering Medicare Advantage plans, so you are a participating provider for Medicare Advantage plans through, say, Delta or through Humana or through United Healthcare, they are all going to require you to take fraud, waste, and abuse training. And this is new to you. I understand this is new to a lot of people, but probably by this time next year, I'm going to say it shouldn't be new to you. Go to the website and find out what the training is that particular carrier offers. Better yet, go and listen to the full webinar, the mid-year check-in, so that you can find out in more detail where you can go for that training. It is yearly and it does cover everybody in your practice. Now, the next one is, and actually the other question that came off of this is, what if we are out of network? And do we need to do fraud, waste, and abuse training, even if we're just say, maybe we're out of network with Delta, we're just filing the claim for them, but it's a Medicare Advantage plan? So here's my answer. I checked with a ton of lawyers on this, and I was told by most of them that yes, because you are doing business with the federal government via Delta, you're still doing business with big Medicare, but it's Medicare Advantage, that you then fall under that umbrella. Are the chances of you getting audited for noncompliance big if you're out of network? Not at all. But, could something happen? I suppose. I always want to be not risky at all. And so I would just go ahead and have the whole office do it. To be frank, I really wish every office in the country took some form of fraud, waste, and abuse training. I think it would make us billers stronger and more knowledgeable. And I think it would get doctors to understand that there are certain rules and regulations just around billing services. So I've seen a ton of offices out there where the billing person comes up to me after a class and says, hey, I'm supposed to bill for every procedure. I'm supposed to bill this, this, and this, no matter what, if we did it, because it makes up for the low PPO fees. And it's like, wow, can be really the Wild West out there. So I'm okay with everybody taking this training. And especially if you're bringing in associates, you want everybody to understand why you are billing ethically in your office. And perhaps they came from an office that was not quite as ethical. And now you've got to, I see this all the time. Associate comes in and they're used to billing for this, this, and this, even though they didn't, provide it, but because that's what was done at the old office. And now they're wondering, okay, why is my production not up? And it's because we're actually not going to bill for these phantom procedures that they were billing for years. Very, very uncomfortable situations. And as the manager, as the insurance coordinator, it's on me to educate the rest of the team about ethical billing. Oh, sorry, I didn't read this question that was on the screen. Sorry. Okay. Are all Medicare plans required to pay off of the PPO fee schedules? We're in network with Aetna and United Healthcare. And we have seen them pay 100% of our fee, but then some pay the PPO. So all the Medicare plans are different now. There's no one size fits all. For example, my parents' plan, both of them, they have individual plans. Both of them are $3,000 yearly benefits, and they pay whatever I send in. I sent in a crown. I sent in a crown for one, and they paid it. I sent in a crown for another, sent in documentation, and they paid it. So I'm like, honestly, they paid it so quickly. I don't even think anybody looked at the X-ray. Not all plans are going to be conforming now. You're going to see so much plan variation. So you should find out. Hopefully they give you the documentation. And if you look at the mid-year check-in, you can see where you can go for some of these Medicare Advantage specific plan designs. And some will pay 100% of your fees, and some are not going to pay anywhere close to that. I'm just going to pull out my foggy crystal ball and say that we are moving towards Medicare Advantage plans not being so generous in the next 2 to 3 years, because some of the plans were overly generous. And I think that that's, biting them on the back end when they start to look at their numbers and was it as profitable as they thought it was going to be. So enjoy those $3,000 yearly benefits now. I fully expect it not to be that way later. Okay. Having trouble getting a straight answer, but is Medicare always primary? Okay. You knew I was going to say this, right? It depends. So what I did was, and I'll put this in the show notes, I gave you two links here. One will take you directly to Medicare.gov, and it actually is a very interactive thing, like click here if this and click here if that. And let me see if I can get it to work on this particular, share this tab. Yep. Okay. So hopefully you can see this, and it says, do you have health coverage other than Medicare? I'm going to say yes. And then what kind of other coverage do you have? I have group health coverage. What's my age? For purposes of Medicare, I'm going to say I'm 65 or older. And then how do I get my group health coverage? Well, this is for the most part, I'm covered under former employer or my spouse's former employer. So this is retiree coverage, right? I'm covered under my current employer. So I have current active benefits. So say I work at Boeing full time, but I'm also Medicare eligible. So I'm going to click on this one. I'm actively working. So does the employer providing you health coverage have 20 or more employees? This is why all the it depends makes a difference. Yes, they have more. So the group health plan in this situation pays first, and then Medicare pays second. Okay. Now, I'm going to do this again, but I'm going to go with the retiree plan because a lot of people have the retiree plans. Okay, so it's very different here. Your Medicare pays first, and then the retiree plan pays second. Okay, so a very, very easy way to do that. And then I also gave you this one here. So you can see that this here is coordination of Medicare and federal employee benefits. And that is what a lot of us, I'm in the DC area, so I definitely see this a lot. All right, so let's go back here to the presentation. And that is going to be, again, linked in the show notes. So I like the little interactive one because you can teach someone, you can bookmark that and teach someone how to find that out, and then keep the other one handy in case you have a lot of federal employee plans. But there's a couple other, if you Google is Medicare primary, you're going to get a lot of sites, but you have to make sure they're reputable sites. You want to make sure they're government sites and not just some consumer site that, was just kind of thrown together. So there are a lot of great charts out there. Just make sure that it goes with what CMS or Medicare.gov, what they have to say. So the next question is, and then we're going to wrap it up, how would you go about starting the process of looking at your participation with every insurance company? I'm pretty new to insurance. It doesn't matter if you're new to insurance because even, some of us veterans were like, oh man, I better check this out. So don't feel bad about being new to insurance. How am I supposed to look at participation? So it's a long answer. So I'll just sum it up here. And it sounds like I should do another podcast on this. What I'm looking at is what is my write-off, my actual write-off between my fees and the insurance carrier's fees. Then I take a look at how many new patients the carrier is sending to me. So if the carrier's not sending me a lot of new patients, why am I in network with them, right? Like that's the main reason. I'm also going to take a look at those adjustments like we talked about. And are those adjustments over and above what I feel is acceptable? do they end up disallowing more than the appeals than I'm winning? I also am going to factor in how much of an administrative burden this particular carrier is to my team. So doctors, if you're listening, one of the questions I always ask is, doctor, which plan do you really dislike the most? And the doctor's plan, when I ask the team that same question, the doctor's plan is always different than the team's answer, because the doctor is looking at the numbers and they don't like the disparity. I get that. The team, though, is thinking, every time I submit a plan or a claim to this plan, I've got to resubmit it. They always ask for additional information. I'm on hold with them the longest. I play phone tag with them the longest. Their portal is awful. I can never find any information. That is the plan that I would take a look at, right? Now, if your fees are fantastic through that plan and you think your team could suck it up a little bit, that's a conversation to have. But if the fee schedule is not great and your team is actually getting stressed out more and more because of that particular plan, to me, that's the clear answer. So lots of different factors in how to assess participation. But another macro factor is, what are the big plans in your area and how many offices have moved out of network? And basically, are you in an area where lots of companies are moving into, and then is there a lot of population growth in your area? Because in order to continue to grow at a network, first of all, you got to spend some money on marketing. And second of all, you need to have a patient replenishing, right? And in a community where jobs are leaving and people are leaving, that would not be a smart play in any situation, right? So very good questions that came from this webinar. And like I said, I will make sure that the actual webinar link is going to get posted, and then the links from the Medicare site are going to get posted. And I hope that this has been super helpful for you. And as always, you can leave a comment or a question through my website, or you can also, if you go to the contact form of my website, you can actually leave me a voice message too. I've gotten some pretty fun voice messages from some of you there. And until the next episode, as always, I truly appreciate that you spend your time with me.
We're all super busy, so thank you for making time for me today. The show notes will have any links that we referenced in the episode. You can also find links for my book, events, and my online insurance course, Dental Insurance Design and Management. I speak often around the country on management and insurance issues. Come hang out with me in one of my classes. I promise you'll laugh and learn.